Good morning and good afternoon. Thank you for joining us for our fourth session in PointRight's PDPM education series. Today's session will focus on understanding the section GG ADL function scores. A few notes before we get started. The panel at right houses the session audio information, the session's handouts for download, as well as a Q&A panel. Please submit any questions you have, and if we do not get to them in real time today, we will certainly review them for follow-up. This session will be recorded and distributed to all attendees, along with a link to both the session handouts and your CEU survey, so keep an eye on your email for those materials. We have also added a general attendance certificate at the end of the survey for those of you who may not require CEU credits, but still wish to track your progress in our series. Now I'd like to hand it off to today's presenter, PointRight Senior Healthcare Specialist, Jen Gross.
Great, thank you, Allison, and welcome everybody to our fourth session in our PDPM education series. So as always, this series on PDPM is evolving continuously. In fact, some of the things that we talked about in our first session have changed since then, and that's simply because CMS has been tweaking their plans for how PDPM is actually going to be implemented since they released the final rule. So as always, we are working off the most current information that we have available at this time. And as we continue along, if anything changes, if there's significant enough updates, we will address those in future webinars. So I'd like to give a very, very brief recap of the previous three episodes in our little series in case you haven't had a chance to view them yet. We do have them archived on the PointRight website, so the URL is at the bottom of the slides here, and you'll have this in your handout as well. So first of all, of course, PDPM, the basics. So this was an overview of the patient-driven payment model that gives the big picture, what PDPM is, how it differs from the current RUG-4 model, and what the infrastructure looks like for the establishing the rates. I apologize. Let me start over. My screen, I started the broadcast and I wasn't showing my screen. So let me begin again so the recording is good. So thank you very much for joining us today for our fourth session in the PDPM educational series. So as always, the situation with PDPM continues to evolve as CMS makes changes, and we've been doing these webinars for a few months now, and things have changed even since the first time we made a presentation on the patient-driven payment model. The actual implementation of PDPM has been refined by CMS since they released the final rule. So as always, the information in these webinars is based on the most current available information that PointRight has at this time, and we will make updates and changes if there are really significant changes in future training materials. So here's a brief recap of the previous three sessions in our PDPM series. First of all, the first webinar, PDPM the Basics, gave the big picture overview of what the patient-driven payment model is, how it differs from the RUG-4 model, and a bit of the nuts and bolts of how the different payment components are calculated, what MDS items are used to establish the rates, and how the revenue adjusts over time. So this first session, you can find a recording at the URL at the bottom of the slide and also in your handout. The second session covered the non-therapy ancillary component, and this is something that is quite new. Non-therapy ancillaries are currently built into the RUG-4 model, but we don't really see it. PDPM has brought these different components to the forefront, including diagnoses, treatments, therapies, and conditions that are identified on the assessment of the resident. And these drive the non-therapy ancillary payment component of PDPM. So all the details are in that recording. And then session 3 covered ICD-10 coding, which is a very big part of PDPM, both for determining the primary diagnosis for the clinical categories of PDPM, as well as capturing comorbidities for the speech and the non-therapy ancillary components. So it's very important to make sure that your ICD-10 coding is at a good level of competency in order to appropriately capture these diagnoses. And it really does require interdisciplinary teamwork, as every piece of PDPM does. So that's a brief story so far review. Now let's talk about today's webinar. And I always like to frame the situation, what this webinar is and what it isn't. So we are going to cover in the next hour how the ADL functional scores affect the different components of PDPM categorization. We'll do a little side-by-side of how PDPM ADL scoring differs from the current RUG-4 ADL scoring. I have a couple of examples and some ideas to get the wheels turning for some best practices that you might implement in your own organizations. Now, this is not a Section GG coding training. That takes actually a lot longer than I have in today's session. Of course, training is very important at the ground level for making sure Section GG is coded correctly. I do recommend starting off with CMS's training videos. They have a YouTube channel. The URL is on the screen here, and they have a 4-part series of training videos that are free to use. So certainly take advantage of those free materials from CMS in learning how to code Section GG if you need, if you have new people or if you need a refresher. So today's session is going to cover the details of what parts of PDPM are impacted by ADL functional scores. We'll talk about where from the minimum data set or MDS assessment these items are identified and how they're used to calculate the functional scores for therapy and for nursing PDPM categories. And we'll talk about some ideas and strategies to embed capturing those ADLs in your systems in order to get those ADL scores right off from the get-go and get them coded on that first MDS to set your payment. So of course the PDPM case mix components all combine into the resident rate, and we've talked about, we've used this slide in all of our presentations because all of these components interact in different ways to come up with that single resident rate. Now, as far as the PDPM components that are impacted by ADL functional scores, there's a couple of areas. The PT and OT components, which are kind of combined together, so I'm going to call them PT/OT components, look at the resident's functional status in Section GG on the 5-day MDS. And the nursing component also includes functional status with a slightly different calculation. So we'll be focusing on those areas as well. But first, I'd like to talk about a little background. Why are we using Section GG now instead of Section G, which we've been using forever to calculate ADLs and to set payment? And just as a reminder, Section G is not going anywhere. You're still going to have to be able to code that section and all of your other MDSs. But Section GG is specifically being called out for use in the patient-driven payment model for a couple of reasons. First of all, fiscal year 2019 PPS final rule that laid out the framework of the PDPM model gave their reason for why they're using Section GG, and that is that, well, first of all, the whole reason for Section GG ties back to the Impact Act of 2014, which requires standardized common data elements that will be used across settings in the post-acute space. So SNFs, inpatient rehab facilities, long-term care hospitals, home health associations, agencies rather. These, all of these different fields use certain standardized items in their assessment data sets. So Section GG was added to the MDS to align the MDS coding with those other settings. And also, Section GG is a more comprehensive view of functional status and therapy needs, and what type of activities are predictive of therapy costs in the facility. So, for example, the self-care items are a lot more split out, different aspects of personal hygiene, different aspects of dressing, because upper body dressing is a lot different from lower body dressing, different types of transfers, the distance walked are a lot more specific. They look quite a bit more like a therapy evaluation, even though this isn't just therapy's job. But these items have been determined in CMS's analysis to be predictive of therapy costs. So they're tying that back to the actual reimbursement. Now let's take a look at the basics of how Section G is coded versus Section GG, because yes, we have been coding Section GG for a while now. We should be used to it, but it's I think it's worthwhile to look at the differences between the two, because they really have different perspectives. So Section G, we're looking at a 7-day look back, including the ARD as a last day. And we are coding the resident self-performance in one column and staff support coded in the next column, in the second column. And we're supposed to code them separately from each other, independently of each other. For self-performance, we've got our favorite rule of 3 that is looking for the highest level of dependence that is found 3 or more times during the 7-day look-back period, except for total independence and total dependence, which has to be the whole time, or activity did not occur, has to be the whole 7 days. So if you get through the rule of 3 and you realize that the activity occurred only once or twice during the entire 7 days, there's a separate code for that. And then finally, if you get down to the end of that rule of 3 algorithm, if no one level has been identified as occurring 3 or more times during the 7-day look-back period, you end up coding supervision. That's kind of the default code. Now, staff support is a lot less complicated than self-performance. You're just coding for the highest level of support that happened at least once during that 7-day look-back period. Now, Section GG, on the other hand, is just one item that combines both self-performance and assistance by helpers during a 3-day look-back period. And what we are looking for is the elusive concept of usual performance, not the highest level, not the lowest level, as CMS eloquently puts it in the manual. So when we are talking about the level of assistance, this is based on how much of the effort of that activity is being performed by the helper. So we have no assistance, total independence. We have setup and cleanup help. We have supervision and queuing. Then we get into the actual physical assistance with the activity itself. So less than half of the effort versus more than half of the effort for that activity. And then there's total dependence. Helper does everything and the resident doesn't even participate in the activity. That less than half and more than half is where you really have to discuss and hash out what level of effort that usual performance lands at. Now, if the activity didn't occur, there's different reasons for that now. So you can tease out, did this activity not occur during an entire 3 days because the resident was bedfast with a total non-weight bearing restriction? Or did the resident refuse? Or was there an environmental limitation? The reason why that activity didn't occur in the first 3 days of the Medicare stay can really help you plan going ahead. Now, there are multiple Section GG items that are used in the 2 different PDPM ADL functional scores. So on the left, the same functional scores used for PT and OT, because that category is kind of combined. We are looking at 3 self-care items: eating, oral hygiene, and toileting hygiene. Then we've got 3 mobility or several mobility items, 3 that are related to kind of bed mobility, sit to lying, lying to sitting on the side of the bed, and then sitting to standing kind of goes into, sit to lying and lying to sitting on the side of the bed are the 2 bed mobility, and they're combined to each other. So I'll just add that highlight. And then there are 3 transfer items: sit to stand, chair or bed to chair transfer, and then toilet transfer. So these are 3 different types of transfers. And then we have the walking items, 50 feet with 2 turns, or walking 150 feet. Now, the PT/OT functional items and the nursing functional items have a lot of overlap, but there are a couple of differences. Nursing does not consider oral hygiene, and it also doesn't consider the walking items. So it's a truncated score, and you'll see that come up in the calculation. So when you have coded the MDS and the 3 days are over, then you end up scoring the section GG ADL function. So once you have determined what the resident's usual performance is for that particular item, you'll code anywhere from totally independent, or maybe with setup assistance, all the way down to total dependence and the activity didn't happen. So if you're coding setup assistance, that's a 5, or total independence is a 6. That will give you a score for that item of 4. Then supervision or touching assistance. Now, touching just means, contact guard. It's not actually assisting with the activity. It's just a hand on the resident to perhaps steady them or to direct them in the right direction, but not actually helping with the activity. So that's a 4 on the MDS, and that translates into a score of 3. Partial moderate assistance and substantial maximal assistance. The difference between those is partial moderate is less than half of the effort done by the helper. Substantial maximal assistance is more than half of the effort done by the helper. And as you can see here, the score goes down the more assistance the helper does. When we get all the way down to total dependence or didn't happen, whether the resident refused or is not applicable or it was not attempted, then you get down to a score of 0 for that item. So the more assistance / dependence, the lower the score is, which is a total difference from the way Section G code scores ADLs. So another side-by-side comparison. Section G ADL scoring looks just at 4 late loss ADLs. These are the ones that in the normal course of decline are the last to go. Eating is scored separately from bed mobility, transfer, and toilet use. The scoring is you have to do some funky math to combine the self-performance and the support scores. Independent supervision or occurred only once or twice, or activity did not occur. Those are all scored 0. And then hands-on assistance, here's the big difference. A higher level of dependence means a higher score up until activity did not occur. So you have a range of 0 to 16, but the general principle is the more dependent the resident is on staff, the higher that ADL score is. Now, the flip side of that is Section GG. It's a combination of 10 ADLs, some early loss, some late loss. And I already showed you there are all 10 ADLs for PT and OT, 7 of them for nursing. Now, I pointed out those mobility, transfer, and walking items that are grouped together. Those scores are averaged to come up with the final score. Now, here's the big difference. If the resident is totally dependent, it's scored 0, just as if the activity did not occur at all. Now, for hands-on assistance, if the resident has a lower level of dependence, if they're doing more for themselves, you'll get a higher score. And then independent or supervision only is the highest score possible. It's scored a 4. So it's a flip. It's turning the ADL scoring on its head, basically. You get more higher points for more independence. And that's, again, back to CMS's original study that determined that it's not the people who are totally dependent that are tied into the highest cost. It's the ones that are more active, are doing at least something for themselves. They tend to be more interactive with therapy, take up a lot more time than the folks who are just totally dependent and staff is doing everything for them. So the range for PT and OT, because there are more items, it goes all the way up to 24 from 0, and nursing goes from 0 to 16. So when let's take a look at our little grid of the different PDPM components to see where the ADL functional scores fit in. So there are ADL score that is for the PT and OT components. Those have the same score. And then we have the nursing component, which also factors in that slightly smaller ADL score as well. Now, ADLs do not impact the speech component or non-therapy ancillary, and of course the base rate is not impacted. So very high level overview of the differences between RUG-4 and PDPM. I thought I would come up with a couple of examples of residents that you might see in your facility. And if you assess them today under RUG-4, what would they look like? And let's talk about after October 1st, 2019, what they would look like under PDPM if you were assessing them for the 5-day. So let's start off with Mr. A. Now, Mr. A was admitted to the SNF for PT, OT, and speech following a CVA. He has right-sided hemiparesis. He has difficulty with speech, difficulty with swallowing, so classic high-level, high-intensity therapy after a stroke. He's non-ambulatory, at least as of the 5-day. So he needs a very high level of assistance with bed mobility and transfers and toileting hygiene. He's not totally dependent, but he does need heavy-duty assistance of 2 or more staff. Partial or moderate assistance with eating and oral hygiene. So he does need assistance with some of those fine details and assistance with eating. He has a mechanically altered diet because he has swallowing issues from the stroke. So he's getting PT, OT, and speech 5 days a week, $7.20 a minute. You know, you probably already knew that just by looking at the resident. Now, he also has type 2 diabetes, he has retinopathy, he's on insulin every day, and he's had insulin order changes and moderate cognitive impairment. So again, don't just look at that first bullet, because PDPM is looking at the other 2 bullets as well to come up with the overall payment. Now, just considering Mr. A's ADLs, I've already said that he needs a very high level of assistance with bed mobility and transfers. So I'm saying weight-bearing assistance of 2 or more staff, so 3 and a 3. And as we know with RUG-4 math, 3 and 3 equals 4. For eating, he does need a little bit of touching assistance, non-weight bearing, to get him to complete his meals, and also, you know, just to somebody stay with him and make sure he's swallowing safely. So it's a 2 and a 2, only 1 person, and that gives a score of 2. And then toilet use is similar to transfers because toilet use includes transfers. He's not quite up to the point to transferring onto the toilet, but he is not bed fast, but he generally uses the bedpan. So high level of self-performance. He's not total dependent. Again, he is able to do a little bit of assistance on this unaffected side with turning himself, maybe reaching over to the bed rail, but he still needs assistance of 2 people in order to accomplish the toileting program. So we have a score of 4, 4, 2, and 4, which would give an ADL score in RUG-4 of 14. That's enough math for today, right? So that, of course, he'd had 720 minutes of therapy, so that puts him in an RUC category. Again, no surprise, you can picture Mr. A in your head. Now in PDPM, here's what those functional scores would come out to. So for eating self-care, he does need some assistance, but quite a bit of effort. So the MDS code would be a 3, which would give a score of 2. Oral hygiene is the same thing. He needs physical assistance for that. So that would give a PTOT score of 2. Now for self-care, the toileting hygiene, sit to lying, lying to sitting on the side of the bed, these are a little bit lower of a score because he needs a little more heavy-duty assistance with turning and positioning and getting himself around in bed so to accomplish these ADL tasks. So each of those is coded as a 2 on the MDS, and a 2 would give you a 1-point score in PDPM. Now let's get into the mobility. The three transfer items: sit to stand, chair and bed to chair transfer, and toilet transfer. Well, he's already non-ambulatory. He cannot yet stand. So that's an 88, not attempted due to medical and safety reasons. Same goes with toilet transfers. But the chair, bed to chair transfer, they have been doing a very extensive assistance bed to chair transfer. He's not totally dependent. He's not using a Hoyer lift, but it does take a lot of assistance of 2 or more people. So that would give you a score of 2 for that item. Now for mobility, walking 50 feet with 2 turns or walking 150 feet, of course that did not happen. He's non-ambulatory, so there's 0 points for that. Now, so how does this come out in the score? Well, it's easy to add up 2 and 2 and 1, and we have 3 so far. Now we have to average out the mobility items for bed mobility. Now this is easy because there's only 2 items, so you're averaging them out. It comes out to an average score of 1. Now the mobility at the bottom is easy because it didn't occur, so we've got a 0. Here's where the funky math comes in, because the transfer items, you're averaging out 3 items. So it's not going to come out very easy. You do have to do a little bit of a math here, and I checked this in the RUG calculator that CMS provided us, just to make sure, well, how do we handle the rounding? Because that is something that really wasn't spelled out in the PDPM crosswalk materials. But if you're averaging 3 things, you're going to have to round somewhere. Well, in this case, a 0, a 2, and a 0 gives you an average of 0.333. You're going to round that down. It's mathematical rounding, so that comes out to a 0. So that's something I had to kind of investigate a little bit and do a little playing around with the PDPM calculator that CMS has distributed. So that comes out to a total functional score of 6 for PT and OT. Now for nursing, same story. It's all the same items, except we're missing a couple. There's no oral hygiene and there's no walking items. So remember, we are averaging out these 3 transfer items, and that is coming out to a 0 because we have to round down if it's less than 0.5. So that gives me a score of 4 for the nursing category. So how does this play into the components for Mr. A's payment? So if we look at his PT, OT, and speech categories, he had a stroke, so his primary diagnosis is related to that stroke, his hemiparesis. And so that puts him into the acute neuro categories for both PT, OT, and speech. And his ADL score is 6. So his PT, OT component is a TN, and his acute neuro speech category is an SL because he's got several comorbidities. Now that ADL score of 6 plays in to establish where he sits in the PTOT calculation. Now for the nursing and non-therapy ancillary components, his diabetes and his retinopathy and his order changes put him, and the hemiplegia, puts him in a special care high level, and his ADL score of 4 makes him an HDE1. And of course, the non-therapy ancillary score, he's got the diabetes and the retinopathy, so that gives him a score of 3, gives him an ND. So tons of moving parts, but our main focus here is where the ADLs fit in, the PTOT component and the nursing component. So one other example, Mrs. B. So Mrs. B was admitted to the SNF after a fall. She's getting PTOT, and she needs a little buffing up, a little strengthening. She is mobile, but is very deconditioned. Now, after the fall, she got worked up at the hospital, and x-rays found osteoporosis with pathological fractures. May or may not have been there accompanying the fall, but she has some compression fractures in her spine. She can walk 50 feet with partial or moderate assistance, and she needs a lot of assistance with the bed mobility. She's got limited mobility because of the osteoporosis and pain from the fractures. But once she is sitting up, she's able to transfer with partial or moderate assistance. She can bear weight. And she needs a little supervision with eating and oral hygiene because she's got very little stamina. So she's getting PT and OT 5 days a week, 500 minutes total. She's got a low BMI, diagnosis of malnutrition, again, partially because of her deconditioning. She has a mechanically altered diet, COPD with an acute exacerbation, mildly cognitively impaired, and some moderate symptoms of depression. So again, don't just look at the very top or the middle bullet here. Look at the big picture to see where she would fall. So for the RUG-4 ADL coding, this would be a little bit different because Mrs. B needs a little bit more assistance in bed mobility and transfers, but she's not totally dependent. So we're looking at a self-performance of 3, weight-bearing assistance, staff support of only 1 person. She's not heavy. She's able to participate. So she really doesn't need 2 or more staff to assist her with these items. So that would give a score of 2 for bed mobility and transfers. Eating, she needs supervision, setup, a lot of cueing, but she is able to feed herself. So it's a score of 0 for the eating, just supervision. And then the toilet use, again, similar to transfers, she's a 3 and a 2, self-performance weight-bearing assistance with 1 person. So that gives her an ADL score of 6, and that would make her an RVB if you combine it with the 500 minutes of therapy. So if we look at her in PDPM, well, you know, her score is higher because she's less dependent. She needs just supervision with eating and oral hygiene, so she's got a score of 3, you know, a little bit of assistance, but not very high. Toileting hygiene and is a little bit of a lower score because she does need some hands-on assistance with the moving around and getting cleaned up and adjusting her clothing. Now, for the mobility piece, sit to lying and lying to sitting on the side of the bed, they're both a partial, moderate, a partial moderate level of assistance. You see, I'm still internalizing these terms. So it would be an MDS code of 2, and that would give a PT-OT score of 1. Now for the mobility piece, the sit to stand and the chair to bed and bed to chair transfers are a little bit higher, a little bit more independent rather. The score is higher because she needs a little bit less assistance with those rather uncomplicated transfers. Toilet transfer, she does need a little bit more weight-bearing assistance because it's a little bit more of a complicated transfer if you're getting on and off a toilet versus getting on and off the edge of a bed or a regular chair. And you know how the bathroom is, there's very little room to move around. So she does need a little bit more assistance with that. And then lastly, mobility, she can walk 50 feet with 2 turns, but she can't walk 150 feet. So that activity did not occur. So that gives us a score of 3 for eating, 3 for oral hygiene, 1 for toileting hygiene. The bed mobility items average out to 1. The sit to stand and the other 2 transfer items, they average out to 1.666. So in this case, the decimal is above 0.5, so you're going to round up to 2. And then lastly, the walking is an average of these 2 items, but the 150 feet did not happen, so that's a 0, so that averages out to 1. So she has a total functional score of 11 for PT-OT. Similar story with nursing, again, fewer items. The walking is not considered here. So we're looking at a 3 for eating, toileting hygiene is a 1, Sit to lying and lying to sitting on the side of the bed is a 1 as well. And then the average of mobility items is rounded up to a 2. So that gives her a total nursing functional score of 7. So how does this break down in the PDPM components? Well, first of all, we start off with the clinical category. She has those pathological fractures. So it turned out that that was really the primary reason why she was still in the SNF getting that therapy, even considering all the other things going on with her. So she's in the non-surgical orthopedic category. Her ADL score is 11, so that's a TG for PT and OT. She's non-neurologic. She hasn't had a stroke, but she does have moderate cognitive impairment and a mechanically altered diet. So that puts her speech therapy category at an SE. Then for nursing, she has a COPD, she's got the shortness of breath, she's got moderate symptoms of depression, so that puts her in an HBC2 category, special care high, with an ADL score 7. And then the COPD, the diagnosis of malnutrition, would give her an non-therapy ancillary score of 3, so she as well is in the ND category. See, this is why we want our software grouper to do all of this for us, because there are so many components to PDPM. But this is something that is going to take time and practice to sort of internalize, because we were used to eyeballing a resident and getting a pretty good idea of what their ADL score would look like, both in RUG 3 and then we recalibrated in RUG 4. We got a pretty good idea if a person is a B or a C in a rehab category. This is so much different because of the 2 different scales and the fact that that Section G is looking for dependency, where Section GG is looking for the resident's abilities to do things. So let's kind of talk about some of these potential trip-ups, because there is a difference in the concept of how capturing ADL's work in Section GG, and particularly how it's applied to PDPM. The first potential trip-up, of course, is not using the interdisciplinary team. Back when Section GG was first implemented, a lot of providers said, oh, well, this looks a lot like therapy eval. It's using therapy-ish language, so it's going to go to the therapy department. That'll be their problem. Nurses have other stuff to deal with. But of course, that's not the best way to approach this. And CMS has said in the manual, in Section GG, that they anticipate that there will be an interdisciplinary team of qualified clinicians that are all involved in assessing that resident during the 3-day assessment period. And they define qualified clinician. They don't say this has to be a licensed physical therapist or this has to be a registered nurse. It says healthcare professionals who are practicing within their scope of practice and consistent with federal, state, and local law and regulations. So what are you normally doing in your role as a clinician in the nursing home? It's within your scope of practice, and part of that is assessing the resident's function day in and day out. So it's really not in any specific disciplines bucket to assess Section GG. Now, moreover, I mean, we have a very, very tight time window here. We're looking at the resident's usual ADL performance, so you can't have just one evaluation that takes 45 minutes and call it usual performance. Of course, that doesn't work. So you need to look at the entire 3 days with input from overall shifts, because the intent, of course, is to get in there the first 3 days to assess baseline performance. Even if therapy comes in on day 1 and really starts out, it's going to take a little while before the benefit of that therapy is showing up for that resident. So you don't have to hold off on that therapy treatment to get for 3 days to get that assessment. The idea is that the benefit, even if therapy starts right away, the benefit of that therapy hasn't yet been realized in the first 3 days. And of course, we all know some residents perform differently with the therapist than they do on the floor with the CNAs. We all know this. So knowing that, we need to have collaboration and input between those different disciplines to really come down on, okay, what was the usual performance for this 3-day time period? You can't just put it in one discipline bucket. And of course, therapy often does not get the resident on caseload right on day one, sometimes not at all. Sometimes therapy is really not indicated at the very beginning of a resident's stay. So you certainly can't put that on therapy to go and assess somebody that they haven't even evaluated to treat yet. So that's the first trip up. I think since Section GG was first implemented a couple of years ago, we've learned from experience, but it's worthwhile to implement that as a rule. Now, of course, usual performance is tricky to come on because, of course, this is not it happened 3 or more times during a 7-day look back period, so you're going to code this. It's very squishy. It's a very vague definition that CMS has given us from the manual. But you really do need the interdisciplinary input here, because I want to call out the definition of usual performance from the manual, page GG9. Not the whole thing, but just the first couple of pieces of that definition. That the resident's functional status can be impacted by the environment or situations encountered at the facility, not just inside the therapy gym, not just in the room or in the corridor, but in different situations encountered in the facility. It may be very different for somebody who doesn't leave their room versus somebody who is right in and very active in the life of the facility from day one. And of course, if you have to observe the residents' interactions with other staff, they often will work harder for other staff members versus the 3 to 11 CNA. And under different circumstances, it might be the time of the day, but it's important to have that input from your different team members over the different shifts during that 3-day time period in order to get that overview of what the resident's functional status is. Now, if your interdisciplinary team is comfortable with setting a criterion for, okay, what are we going to consider usual performance, then please go ahead with that, because if you've identified a method that really works to pin down usual performance, if it works for you, go with it. But CMS doesn't really give us anything specific in the criteria for what to determine. Now, less than half and more than half might be a little easier once you are familiar with how each of those ADL activities works. So again, you need input from the direct care staff over all shifts, not just the CNAs, although I'm sure the CNAs will be doing the bulk of a lot of these activities, but include CNAs, nursing, feeding assistants, of course, therapy. I didn't put them on the screen here, but therapy is involved as well. Over all shifts, make sure that these staff members know all of the pieces of the ADL activity. So toileting, hygiene, not just cleaning the perineal area, but adjusting the clothing, all of that important things, and the different aspects of oral hygiene and different aspects of eating. Of course, remember the eating is only eating by mouth, using appropriate tools to eat by mouth. So just make sure that everybody knows the different parts of the ADL activities, because just like in Section G, there are different aspects of that activity. If you think about it in those terms, then you might realize that, well, I really was doing more than half of the effort for Mary when we were taking care of her oral hygiene, because I was managing her dentures and also helping her clean her mouth, and I really had to do more than half of the effort. Now, The piece of this that is a lot different from capturing ADLs from Section G is making sure that you are assessing how much the resident can do for his or herself, rather than just going right ahead and providing assistance, because frankly that gets the job done quicker if you just go ahead and do it. And it is a tendency in nursing homes to foster dependence in certain areas for the sake of efficiency. We try not to do it, but sometimes it still does happen. So make sure that you are appropriately gauging how much the resident is actually doing for his or herself. Touching assistance and weight bearing, remember touching assistance that's not really helping with the activity goes in the same bucket as supervision. Whereas weight bearing assistance, it's not weight bearing versus non-weight bearing, it's doing less than half of the effort or more than half of the effort in that activity. And of course, making sure that the resident can do the activity safely. If you just step back and watch the resident transfer and they're going to fall over, then you certainly need to do some kind of hands-on assistance. Now the manual has multiple examples, and they keep adding more because CMS has acknowledged that this is a tricky concept for those of us who have Section G so deeply ingrained in our brains. So please refer to those manuals. It's the official source for coding, and again, I recommend their training videos as well. Now, another trip up is not using that full 3 days, because again, 3 days is not a long time, and you got to get that assessment in. Day one, we're talking 3 calendar days. Day one is day one, regardless of if the resident is admitted at 8:30 in the morning or 11:30 at night. That's still day one. So you do need to make sure that your staff on all shifts, all days, are prepared to hit the ground running and assess Section GG items right away, because you want to make sure that you're not just looking at a day and a half worth of information and trying to tease out usual performance from that. Now, oftentimes an activity will not be attempted at all on day one. If you think about bed to chair transfers, for example, it might just not happen on day one. So figure out why. The reason why the activity did not happen. Did the resident just flat out refuse and say, I'm tired, I was in the hospital, I just want to lay down and sleep. I'm not getting out of bed right now. Or were there environmental limitations, or was the resident non-weight bearing? Now, some things cannot be worked around. If there's a total weight bearing restriction, of course, you're not going to get somebody up and do a sit to stand transfer. But if there's something that could potentially be worked around, or maybe the resident will feel better in the morning, make sure that the next shift knows this, so that they can say, hey, let's get out of bed, let's start a new day here. Are you feeling better? So that it can be attempted and you can start gauging the resident's performance. So it's not just that the activity didn't happen, but why didn't it happen? And of course, the activity should be completed safely. Now, I thought I would throw a little curveball in here and stick the interim payment assessment in here, because one of the things that CMS has not sprung on us, but clarified very recently after the final rule was first published, is that the interim payment assessment is going to have its own item set. So instead of using the same item set as the 5-day MDS, the IPA assessment, the interim payment assessment, is going to have its own item set with a new part of Section GG. There's going to be a new column, column 5, for interim performance. So the assessment period is still going to be the same for Section GG. It's going to be the 3 days ending with the ARD, so ARD plus the 2 days before it. And the same coding rules. I mean, it's still all the same items and the same coding rules. It's just put in a different column on the MDS. So you're going to see this different item set in Section GG that will be part of your software system starting October 1st. And you can start triggering those. Now, the criteria for an interim payment assessment, the official word, again, is a change in the resident's classification in at least one component, so that the resident will be classified into a payment component that is different from what was established on the 5-day MDS. So It's kind of like if you took the change of therapy assessment and the significant change assessment and scrambled them up together, because it doesn't have anything to do with the change in level of therapy, because the level of therapy doesn't determine the payment in PDPM. But it is a change in the resident's condition that is enough to change at least one of those payment components so that it would be different from what was already established. So this would result in a smaller or larger change. And again, if you think about in terms of the significant change assessment, the other piece of this is that the changes are not expected to resolve themselves within 14 days. So think of it if the resident God forbid, falls or has has pneumonia, and it's going to take them a long time to recover from it. It may be recovered within 14 days, it may not. But on the other hand, let's say they're on therapy and they're getting better. If they're getting better, they might have a higher ADL score. So think of it that way. Now, the IPA assessment is optional, so it's not 100% mandatory like the change of therapy assessment is. You won't get dinged for not completing an IPA, at least not as of the latest information that we have. But just like the significant change assessment, if you see enough of a change in the resident's function and their condition that would cause the PDPM classification to change, then it would behoove you to do an IPA. It would set the new PDPM categories effective the ARD of that assessment. Now, of course, there are no hard and fast criteria for what would trigger an IPA. We are eagerly awaiting the draft manual, which is supposed to come out in the spring, sometime in the spring, so that we can start to digest where this information will be. Think about in the manual currently, there are pages and pages of information and scenarios for what might trigger a significant change assessment. I have a feeling that would be somewhere along those lines, but looking specifically at those items that move the levers of PDPM. So a third trip up that ties into the IPA assessment is not continuing to track that ADL performance after day 3. Because if you determine that you need to do an IPA assessment, an interim payment assessment, you're going to need to be able to code section GG for the 3-day lookback period of the IPA, the assessment reference date plus the 2 days before that. So I'm not saying you have to fill out section GG every single day that the residents under Medicare Part A services in your facility, but just maintain the habit of keeping an eye on those residents' ADLs. And to me, I mean, I haven't seen this really anywhere else, but to me, again, section GG is looking for the perspective of the resident's ability rather than section G, which is looking on how dependent the resident is. So think of it in those terms. Now, your interdisciplinary team will still need to continue to discuss, because it's not just ADLs that may potentially trigger an IPA assessment. There's other things such as a resolved diagnosis or a new diagnosis or a new treatment that would move one of the needles in the PDPM dashboard. So keep that in mind, and also keep in mind that, as I said a minute ago, somebody's on therapy and they started off being non-ambulatory and now they're walking. That gives you a higher PDPM functional score. So remember that when you're considering whether or not an IPA assessment is appropriate, and also whether it would potentially benefit your rate. So we've got a few minutes left, and I've got just a couple of other slides that talk about operational strategies. We, of course, want to not just tell you what is PDPM, but give you some ideas or food for thought for how you could incorporate preparing for PDPM into the to the operations that you already have in your facility, because, you know, heaven knows you already have enough to do. So, of course, there's so much lies with that 5-day MDS. I talked about in the last webinar, making sure you're capturing diagnoses on that 5-day assessment, because the 5-day, getting that 5-day right is so crucial to setting that initial payment category and setting it right, because of course after a while the non-therapy ancillary is start to taper down, and then the PTOT is going to start to taper down. So you want to make sure you get that initial category right from the get-go. Now remember that ARD window to set the date for that 5-day hasn't changed. It's still day 1 through day 8. 6, 7, and 8 are no longer grace days. It's just one ARD window. But Section GG is always going to look at days 1 through 3. So remember that. You have to get right in there and assess those first 3 days of the stay. So it would probably benefit you to get in the habit of incorporating those Section GG items into your new admission process for your Medicare Part A residents to capture that ADL performance over the first days right away, regardless of the day of the week the resident is admitted or the shift of admission. Now, interdisciplinary input is so important, and I know that you're doing some kind of team meetings for your residents under various payers, including Medicare Part A, on a regular basis. So perhaps an interdisciplinary team meeting after day 3 will give you the chance to say, okay, let's talk about ADLs. Let's see if we can come to a consensus on what the resident's usual performance is. You're probably also going to be meeting to make sure you're determining the appropriate primary diagnosis. You have to set discharge goals on that MDS as well. So incorporate that into that process because there are several things that you need to make sure you get right on the first assessment. Remember that the MDS is not going to go away until it's time to discharge from Medicare, because there's always the possibility during that Medicare stay that an IPA will be needed. So if you have regular Medicare team meetings, whether it's weekly or every single day, just do a quick discussion of ADL performance so that you can address that, see if there's a change that might indicate that something else is going on with the resident that would make an IPA an appropriate approach for your team. So think of it in terms of having a daily RUG meeting right now where you talk about how much therapy was given yesterday and are we still at that same therapy level. Maybe we should start thinking about the same functional level as well as what else is going on with the resident clinically. Of course, that discharge assessment is going to come at the end of the stay, so make sure you plan ahead for that. If it's a planned discharge, you're going to need to do Section GG all over again. You start on the day of admission with those discharge goals on the 5-day MDS, so you want to make sure that those goals are appropriate. Those specific ADLs, of course, you want to make sure you're monitoring those over all shifts so that the resident has the best chance of achieving those goals. And then when you set the date for that planned discharge, just make sure that the direct care staff are aware that, hey, Mary Smith is going to be discharged home on Thursday. Make sure that Tuesday, Wednesday, and Thursday you are assessing those Section GG items so you can get that appropriate usual performance for the end of the stay. Now, the big thing, of course, the hump that people will need to get over is the initial transition. So CMS has stated that this is going to be a hard switch effective 10/1/19. So what that means is your residents who are in your facility covered under Medicare Part A, you're going to need a RUG-4 RUG to bill through September 30th. So that ARD for that assessment that gives you that RUG score will have to be have an assessment reference date before 10/1. So you have that RUG in place. Then after October 1st, a transitional IPA assessment, there's that IPA, we're going to get used to it really quick, is going to be required. The ARD can be no later than October 7th, 2019. 10/1 will, regardless of when you set that ARD, 10/1 is day 1 of the variable per diem adjustment for PTOT and non-therapy ancillaries. So that PDPM payment is going to start on 10/1, but you have to have the IPA set no later than 10/7. So make a plan, make sure that you have the tools in place and the competency there to assess the Section GG interim performance, because you're going to have to do it on the first IPA for those residents. And you're going to make sure that you're setting, when you set that assessment reference date, that people know that you need to assess the performance for the 3 days ending with the ARD. I did look at the calendar as I was preparing for this. 10/7 is going to be on a Monday. So make sure if you are setting any of those ARDs for the interim payment assessment on the 7th, that's going to be on a Monday. So make sure the weekend staff are prepared to assess if they need to. So it's all about teamwork. I love this little screenshot, so I thought I would add that here, because you all have to work together to achieve your goals, whether it's reaching the hamburgers that are on the kitchen counter, or making sure that your residents are getting categorized in the appropriate PDPM categories right from the beginning. So I hope this has been helpful to you. Of course, there's a lot to learn. We're still internalizing it and things are still changing, but always go to the source. So CMS has its PDPM website. They keep adding more and more information. So even if you've gone to this page before, go again, because they keep adding more links. Now, that PDPM classification walkthrough that CMS published has already been revised once, but this is essentially what's going to be Chapter 6 in the MDS manual going forward, where it walks through the RUG calculation. This is basically going to replace that. So that's very useful to keep as your reference as well. So thanks for your time. I know we are just up against the end of the hour, so I apologize for not being able to answer your questions in real time, but I'll pull a report and see if there's anything I can follow up on. The next CEU webinar in our series is going to be a little later this spring. We're going to take a little breather, and we are going to tackle the interim payment assessment in session 4, so stay tuned for that. And as far as getting your CEUs are concerned, I'll leave this slide up for a little bit. As Allison said at the beginning of the presentation, you will receive an email that has a link to our online SurveyMonkey. So if you are attending in a group at a facility, whoever logged into the webinar will receive this email within the next day or so, or you can go right to that SurveyMonkey URL and complete the survey. We do ask that you get your survey responses in by February 1st. We'll give you a little over a week because we do have to compile the final attendance report. But make sure that everybody who attended together today fills out the survey separately, so we can each give them each credit. So you can forward that email if you need to. Now for nurses, when you fill out that evaluation and select that you're a nurse, you can download the certificate after completing the survey. For nursing home administrators, please give us your NAB ID number, because we have to report to the NAB CEU registry after we get our final attendance report. If you're not registered with NAB, the National Association of Long-Term Care Administrator Boards, go to nabweb.org and sign up. They have taken over managing continuing education for nursing home administrators nationwide, so they manage their own registry. For those of you who are not nurses or nursing home administrators, for this webinar and going forward, we also have a generic certificate of attendance, so you can also download that if you need something for your own records. Okay, so thank you very much for attending today. It's been a jam-packed session, and I hope this has been helpful to you. I would suggest start working with figuring out those PDPM scores earlier rather than later, so you can really get a feel for how that differs from the RUG ADL scores and how an individual resident would fall into those categories. So thank you all very much for your time today, and we will see you on our next webinar. Take care.